Chapter 8 is going to cover teeth whitening materials and some of the bleaching procedures that we do with our patients. Some of these slides you'll hear me voice over, and some of them I feel are self-explanatory, so those you can just thumb through. So first we'll start with how bleaching affects what we do as a dental hygienist. As you know, bleaching has become a huge part of private practices today. Everybody wants to look pretty and everybody wants their dark teeth to be white. Some of the things that can cause that darkening of our teeth as we age is the dentin showing through that translucent enamel more. And medications such as tetracycline, we've talked about chemicals, and people's bad habits, drinking coffee, wine, smoking, any type of tobacco, all of those things can cause our teeth to discolor over time. So bleaching can be done in the office or at home, as you guys know, and we can be a huge part of that by taking impressions and fabricating those trays for our patients. The different types of stains that we will talk about are extrinsic, which are probably in most cases the easiest to remove. Those are found on the tooth surface, usually caused by those habits we mentioned, the foods and things that we drink and tobacco, etc. Intrinsic stains are those stains that become more inside the tooth or over time are incorporated internally into the tooth structure. They could have been there all along if it happened during developmental disturbances of the teeth, such as tetracycline or just amelogenesis imperfecta or hyper or hypocalcification. Any of those things could have caused that. These can be hereditary or also related to age. How whitening works exactly is peroxide is the whitening material that's used, and it passes through the spaces in the enamel. It will reach the dentin, and once it gets into the dentin and to those spaces, it oxidizes the stains and therefore lightens that dentin. This process can be accelerated by the use of low intensity heat or high intensity light, such as zoom whitening, that is in-office whitening, where they use a UV light to speed up that process. Hydrogen peroxide and carbamide peroxide are the two whitening materials typically found in our whitening agents. Hydrogen peroxide is what the in-office bleaching agents contain. It is a little bit stronger oxidizing agent than the carbamide peroxide. It is available in a liquid or a gel, and it has concentrations ranging from 5 to 40%, where carbamide peroxide is more popular for home whitening. Also available in a liquid or a gel in concentrations from 10 to 35. There are some 45% gels, but remember that carbamide is a weaker oxidizing agent. And so if you have a 10% carbamide peroxide gel, it would be equivalent to a 3.5 hydrogen peroxide. So I think that's typically why they use it at home. Less sensitivity, less room for error or chemical burns from the material. The different types in the dental office, which is what we talked about, the Zoom, home treatment, which are the bleach trays that we make, and then over-the-counter things such as the crust white strips and paste and things like that. So in-office is also called power whitening. It's similar to the home bleaching, but stronger. They come in the office, and if you YouTube in-office power whitening, it would be helpful because you would see exactly how that's done. They typically isolate the gingiva. We can use a rubber dam, or they can use a material that covers and protects that gingiva from the bleaching agent so that chemical burns aren't caused by this. And it is coupled with the dental light or laser typically. Prescribed in-home whitening is what we do. It's a little bit more cost effective, requires the trays and use of carbamide peroxide solution. Some of those solutions now are adding potassium nitrate to help with sensitivity. So typically it's used also after in-office power whitening. So even if a patient comes in the office and does the in-office power whitening, many times they will be, well, all the time, they'll be sent home with trays and bleach to continue their treatment or to even have for touch-up later on. Now, let's say a patient has a tooth that has lost its blood supply, such as tooth number 9 or 24 in this slide. That is a tooth that's probably sustained some sort of trauma. Over time, the nerve that's found in that pulp chamber turns dark. In order for this to bleach, it has to have what we call the walking bleach technique, where they actually access the internal part of the tooth by drilling a hole on the lingual aspect of the tooth, placing bleach inside of the pulp chamber, sealing that off with a temporary filling, and leaving it for several days. That's really the only thing they can do for these dark teeth. So home whitening is prescribed by the dentist. As we know, it's the most popular and cost-effective way of whitening our teeth. There are some stains that will lighten much better or much more effectively than others. The dark gray brown that we see or blue from tetracycline staining is the most resistant. For these people, they're going to need to whiten up to as long as 6 months. So it's going to take a little bit longer for them to achieve those results that they would like to see. It's always a good idea to have the patient sign an informed consent. We want to inform them of the risks, which are the sensitivity. Sometimes they'll have TMJ issues from clenching into their trays. And then, of course, the benefits are the whitening and things like that. They also want to talk to them about restorative. Restorations do not lighten. So if they have restorations currently in place that are not leaking or causing them a problem as far as decay or anything like that, they'll want to whiten and then have those replaced if they are visual if you can see it in their smile after bleaching, so that their restorative matches their new white teeth. There are standardized informed consent forms out there where we just sign it like we do our treatment plans in clinic, where the patient has been made aware, they agree, they sign, and then we can move on with treatment from that point. Over-the-counter products are usually less caustic, in other words, lower strength. They don't typically cause as much sensitivity, but they also are not as effective as what we can provide in office. There are 4 basic types of over-the-counter products today. The whitening strips are probably the most popular. They also have paint-on whitening paste. You guys may have seen the paint-on whitening pens, whitening gels that are applied in stock trays, and rinses. Potential side effects, we've already talked about a few. Tooth sensitivity is probably one of the biggest ones. Sensitivity in the teeth can be exacerbated by whitening. So with those people, you'd like to have them use a desensitizing toothpaste such as Sensodyne for a week prior to starting treatment, have them use it throughout treatment, and then a week after. Usually the sensitivity for most is short term, and after they complete their treatment with the bleach, it will slowly improve. You can help by shortening your whitening time daily, have them not have it in quite as long. Some people like to wear their bleach overnight just because it's an easy time to do it. For these people, it might be better to just have them do 30-minute treatment times in the evening before they go to bed or in the morning before they go to work. The one thing you want to let your patients know too is once they've bleached, those tubes are kind of wide open. So it's not a great idea to drink coffee or eat foods of color, spaghetti sauce, things like that, because the teeth are going to be more likely to absorb those stains. So you want to give it a little bit of time before you start drinking or eating things of color. We can also adjust the concentration of whitening agent that we provide to them. We have a 16% carbamide peroxide or a 22. If a patient tells you right out of the gate that they have sensitivity on a daily, then you're going to want to go with the lower. You'll give them the 16%. If they have no sensitivity and there are no problems, then it's fine to start a patient off with the 22%. If the sensitivity is something that's becoming a big problem, we may need to stop that process for a few weeks, give their teeth a break, reevaluate what products we're using alongside that, and then resume. Some of the other side effects are the irritation of the gingiva. By using too much of the gel, it can cause that chemical burn on the gingiva or the oral mucosa, and even if it runs down their throat, it can irritate or cause burning in the throat. And then, like I mentioned, the muscles of mastication get sore in that TMJ location from wearing those trays overnight and clenching into the tray. For restorative considerations, cavities should be filled to prevent sensitivity and complications. Now, this is if they have areas of active decay. Those need to be filled before we start applying a bleaching agent, because that bleaching agent could get into those openings in the tooth and really cause discomfort. So whitening typically is a pre-restorative procedure, like I mentioned, but that's only for composites, tooth-colored restorations, veneers, porcelain crowns, things that are seen in the patient's smile. We want to whiten before we would do that kind of work, but know that if they do have decay that's active, that needs to be filled prior to. Microabrasion is another technique that's used to remove non-carious discolorations from possibly mild fluorosis or little hypermineralized spots. So what that is, here's a picture. You can see the white spots on this patient's teeth, and they have isolated with a rubber dam around the teeth. You see the blue in image C. On D, you can see that coarse material that is placed on the tooth. That is a combination of abrasive as well as acidic agent. And then in image E, they are using a prophy cup. So they are going to spin that prophy cup on that material, and the acid and abrasive in that will take off microns of tooth structure. So you want to be really careful how much speed you're putting to that, and you can only do so much with that. You can apply that 2 times. I think 2 to 3 times is the maximum, because you don't want to take off too much enamel. But if you look at image F, you can see how nicely that removed it. So this would be great for someone that just had those surface white spots. And if you did this and it didn't remove at all, then you would maybe turn to a bleach or something like that to finish that process for them. So basically that covers bleaching.